Respected delegates, friends, professors, first of all, I wish to thank Dr. Vandana for giving me this opportunity to tell something about what I know in pediatric spinal anesthesia. So whenever I talk anything on academics, I put a big salute to the legendary teacher of 2 centuries, Dr. Ravi Shankar, who is currently the e-director or e-learning director in Mahatma Gandhi Medical College. When you go to the history of spinal anesthesia was probably the earliest form of regional anesthesia. That is what you have to understand. It's the earliest form of regional anesthesia, useful practice. It was popularized from 1990s. You see here, 1901 it was started, but it is in 1991. Now we are going more towards this ultrasound, infusion pumps, all these things, and we are forgetting this grand old technique of regional anesthesia. So why it came to limelight like this hills? Premature infants, they come with hernia. We are afraid of whether they go into apnea. About giving GA, neuromuscular diseases for lower abdominal and lower arm surgeries. Now, the safety and success of spinal anesthesia has been also proved in pyloromyotomy, gastrostomy, meningomyelocele, genitourinary procedures, even cardiac catheterizations, high-risk cases. What I have done is almost like pyloromyotomy, gastrotomy, some sort of meningomyelocele repair, all type of genitourinary surgeries I have done. Now, when to consider in spinal end? Facial dysmorphia, difficult intubation, muscular dystrophy, family history of malignant hypothermia, full stomach, where we consider GA is little risky in infants. What are the contraindications? Coagulation abnormalities, yes, that's a routine thing. Uncorrected hypovolemia, patient refusal, uncooperative child, increased ICP, and procedure lasting more than 90 minutes. Sometimes if there are any neurological disorders. Now, if you go on to see what is the difference between adult and a pediatric in spinal, where does the spinal cord end? It ends in adults in L1 while it is in L3. That is why we need to choose L4-5 interspace for dural puncture or at least an L3-4. The intercostal line, the so-called Toffier's line, crosses the midline at S1 interspace in neonates and L5 interspace in older children. The subarachnoid approach requires a straighter trajectory. See here, the distance is small, the CSF may be slow, ligamentum flavum is thin, lamina are not cartilaginous. So no to paramedian approach because lamina are cartilaginous, they are not bone, so they may get injured. CSF volume is 4 ml per kg instead of 2 ml per kg in adults and 50% in spinal cord compared to 25% in adults. That is why the duration is very short. Even bupivacaine, which is maximum is 90 minutes and sometimes it goes off in 45 minutes. Characteristics of null fibers, small nerve fibers, may be non-myelinated, small distances between nodes of Ranvier. The lordosis is absent, but in 2 years it may be present. Because if there is no lordosis, the positioning is easy. In adults, what we need is to remove the lordosis by positioning, but that is not much needed in pediatrics. Differences, fibrous sheath around nerves are not well developed. Myelinated is not complete around 2 years. Immature cells, because we need to give less concentrated solutions, and they may get dense block. The length of the spinal cord is 20 centimeters. That means the length to weight ratio is 4 to 5 times. So that is the dose differences is there. Now positioning, flex the back, but sometimes you need to extend the neck because if you flex the neck, they may obstruct. Sedation is questionable. That depends upon the technique or the expertise of the spinal anesthetist. Even locally, EMLA 16 minutes before, ready with airways. Sometimes we start giving IV access even after spinals. That is very questionable. People are very hesitant to do this. Now you see, this is the position. Here you have to need a lot of gap here because I will tell again. See, there is an extension here. It's an extension of the neck. A new non-touch technique of administering spinal anesthesia. This is my article, where what I do is I keep the position little. Here you can see the position is not in the tip. The back is not in the tip, so that you don't touch the baby back. Just the fluid get and then inject without touching. But you need something for the hand. That is why we need to have a sterile towel here and hold the hand here. For that you need the distance. If this tip is of the back is here, then we cannot do this. Standard monitors IV access distance is 0.03 to height is so many this thing. Distance in millimeters is 8 in years plus 10. Aspirate and slowly inject. Don't lift the legs. Sometimes 22 gauge may also be okay. 8 in years into 2 plus 10. For example, 2 years 2 into 2 4 plus 10 is 14 centimeters is what is the classically described. But I don't get this thing. Now you see which is my metazolam. Here you can see this is my metazolam. When you keep it inside this puppy into the mouth, yes, the baby is totally fine for giving the spinal. And now the surgery is starting. Tourniquet is applied. They are going to keep the cautery. Sitting spinal neonate 2.5 centimeters, they may have a short needle. You don't need to gear the position. See here. Don't flex the neck. The ligamentum is very soft, so a distinctive pop is not achieved. Be gentle and slow. Inject the dose. Last, always I do is 0.2 ml or 0.5 ml of little 0.1 ml of air I inject, so that you will be giving the precise dose. Nothing stays in the needle. Now you see, there's a straight approach. That's what I told. No parameter. Assessing the block is difficult. Response to cold spray can be useful. Observation of paradoxical. All these things have developed. But what I do is I simply do a superficial abdominal reflux. That is gone means the level is umbilicus. Theta. Pacifier nipple. The spread of the block is less predictable. High level means there is no BP fall, but apnea, so bradycardia. All these things are more important than BP fall. Whoopee and tetra. Heavy bupivacaine 0.07 to zero point 0.2 ml of 0.5%. Can we remember all these things? 2 kg infant. For 6 kg, if you calculate this, it will be 0.5 ml. There are so many formulas. You have to empty the needle by giving 0.1 ml or 0.2 ml of air. See here, if you want infants, 0.5 to 1 mg per kg. Bupivacaine. Here 1 to 7.5, 0.3. This is so many dosage schedules are there. Additives, epinephrine wash we can give, neostigmine, clonidine, morphine only for cardiac surgeries. Epinephrine, neostigmine, fentanyl, clonidine, midazolam, all these things I have given except morphine in very low age people. Now we can see this is the evaluation of efficacy. This is Partha's formula, my formula. If age is there, so much milligram of bupivacaine you give for all infraumbilical surgeries, especially in 3, 4 or 2, 3. For example, 7 years patient, use 7 milligram, you can do all infraumbilical surgeries. For a routine child, understand, this formula is something like 3 milligram per kg of thiopentone. Some patients you need only 2, some patients you may need 4. You have to adjust. Age is 6 means 6 milligram of bupivacaine. Less than 6 months of age, immature hepatic metabolisms. Failure rate may be 10 to 20%. Bradycardia, okay, but hypotension is not there. PDPH may present with restlessness and hearing loss. We give caffeine and epidural blood patch in pediatrics. I have not given, and it is not actually needed. That is what my concept is. Potential traumatic puncture and blood. This is very common. But overall, complications are rare. Because the sympathetics are not well developed, blood volume is small in the lower extremities, everything is fine. Shivering high levels may impair thermoregulation. This is what is important. No nausea, vomiting. What we get is only bradycardia. and hypoxia. That is what we need to be worried about rather than hypotension. Yes, premature apnea is common. The incidence is not well established, but we don't know about midazolam or deriphyllin or the ketamine, whether this is the cause of apnea. But sometimes they describe the caffeine. I use a very minimal dose of deriphyllin IV prior to spinal. Spinal anesthesia with an indwelling catheter reduces the stress response. You see here, put a catheter in spinal response and do a pediatric open heart surgery. Laparoscopic surgery in infants under spinal anesthesia. A case infants, you see, lap hernia. Case report of 3 cases. Now, who argues for this? No GA. Yes, apnea is less. We are giving very less drugs and it is very cheap. We are not going to bother about airway. We are not going to bother about kidney, liver, all these things because we are not going to give so many drugs like propofol, vecronium, all these things. So we need not bother about the liver maturity or the kidney maturity. GA drugs and baby CNS concerns. There are a lot of things going on now. There is some cerebral cell apoptosis, the growth is less, or the intelligence factor, all these things. We don't need to bother if you give just 1 ml of bupivacaine into the intrathecal space. No PONV. We don't have environmental concern of giving halothane or isoflurane or sevoflurane into the atmosphere, nitrous oxide into the atmosphere. We can do so many surgeries. What I have told is so many surgeries, lower limb surgeries, pelvic surgeries, herniatomies, hydrocele, anal surgeries, appendectomy, so many surgeries. And now we have included pylorectomy, gastrostomy, and even some cardiac surgeries. Overall, against for this. Yes, because the duration of action is limited. Yes, the surgeon should be good to finish within 45 to 50 minutes. If it prolongs, yes, we may not know. Mental inhibition among anesthetists. Yes, slightly spinal curriculum. Will the brain be affected? Will the spinal cord be affected? Am I good? Am I sure? Will the baby approach? Will the baby accept for it? All these things are questionable mental inhibitions that we should throw out. Awake, unsettled infants in kids. Yes, this is we in my place. I don't give so much of sedation because our technicians, our setup, and so-called my expertise of giving these spinals for the past 25 years has given me this opportunity to give in infants and kids without much of sedation. Now, the indications we all know the indications started with in this thing what you call as lower limb surgeries, the club foot repair. Then we went to limb surgeries, osteomyelitis, slowly pediatrics, herniatomies, hydroceles, and anal surgeries, neonatal anal surgeries. Went on to do the appendix, umbilical hernias, slowly moving on to pyloromyotomy, all these things. The differences all we know that it is spinal. We don't need lordosis coverage by keeping the position so much flexed, and ml per kg is 4 ml per kg in the infants. There are so many things as because the spinal cord finishes at L3 and we need to give L34 or L45. The dosage which I have described is milligram. How many milligrams? How many years? Age-based formula 7 years 7 milligram, 3 years 3 milligrams. That is only from 2 years to 12 years. Not for infants, 4 milligrams for 4 years. And drugs I usually give 0.5% bupivacaine hyperbaric. Yes, we all know position. We don't need to flex. We don't need to extend the head and neck. And we keep the position little out of the tip of the table. That is very important for us to have the dexterity in giving the injection. If we touch the back of the baby during injection, the position will go off and we will land up in failure. After you get a CSF, don't touch the baby. That is what is very important. You need to have this dexterity to tighten your hub, hub into the syringe and keep your hand in the table because the baby is not in the tip. That is very important. Yes, complications, they are there, apnea and what you call is bradycardia, failure, very less duration. All these are problems, but sometimes we need to be worried about if there is any spina bifida because coagulation abnormalities, infection at the site, and baby is not very cooperative. All these things our parents are not accepting. All these things are little against. Drugs, yes, we can add chlorine, we can add neostigmine, we can add fentanyl, we can add midazolam, but I have not added morphine. As far it is very simple, cheap, single shot procedure, no drugs, don't worry about renal failure, liver failure, all these things. Yes, the airway is intact, everything is fine, but we need to throw away our mental inhibitions and we need to be studied or working together with a good surgeon. Thank you.